Welcome to another deep dive. Today, we're stepping into the critical care world, focusing on airway management and patient monitoring.
It's a fascinating area.
It really is. We'll be referencing training materials from SSGT Haley Simoneau's Critical Care I course. So if you're a medical student, a seasoned pro, or just curious, there's something here for you.
Definitely.
Let's start with the foundation. Why is airway management so crucial in critical care? I mean, picture it. What happens when someone can't breathe effectively?
Well, it's all about oxygen. When a patient can't breathe, their body essentially starts shutting down.
Hmm.
Organs can't function without that oxygen, and, well, it can be fatal.
Right, it's the most basic need.
In critical care, we see patients who, for all sorts of reasons, can't maintain their own airways. They might be unconscious, have a severe injury, or a medical condition affecting their breathing. That's when airway management comes in. We need to get that vital oxygen to their lungs.
Okay, makes sense. So how do you do that? The course materials cover a whole array of manual breathing devices.
Oh, yeah, it's like having a specialized toolbox.
Exactly. So what's the most basic tool you reach for in this airway toolbox?
Probably the simplest one is the oropharyngeal airway, the OPA.
OPA.
Yeah, it's basically a curved piece of plastic. You insert it into the mouth to prevent the tongue from blocking the airway.
Ah, so it's like a little tongue guard.
Yeah.
Sounds straightforward, but I'm guessing there's more to it than meets the eye.
You're right. Even though the OPA is simple, using it correctly is critical. Like if you insert it upside down and then rotate it, it's less likely to push the tongue back.
Yeah, that makes sense.
Yeah.
Would you ever use this on a conscious patient?
You have to be careful there. Using
Yeah.
an OPA on someone who's conscious or semi-conscious can trigger their gag reflex.
Yeah, you wouldn't want them to vomit when they're already in a delicate situation.
Mm-hmm.
So what's the alternative for conscious patients?
For those patients, we might use a nasopharyngeal airway, the NTA.
NPA.
It's a softer, more flexible tube that goes through the nostril. It bypasses the tongue altogether.
That sounds gentler.
It is less likely to cause gagging.
Okay, so OPA for unconscious patients, NPA for conscious ones. Are there situations where you choose an NPA even if the patient's unconscious?
Oh, definitely. The MPA is useful if we need to suction their nose a lot or during procedures like bronchoscopies where we need access to the airway.
Ah, I see. So it has its own set of advantages.
You do have to watch out for nosebleeds, though, especially in patients with bleeding disorders or those on blood thinners.
Right, that makes sense. So we've got OPAs, NPAs. What happens when you need something more substantial, like when someone needs help breathing for a longer time?
In those cases, we might consider a laryngeal mask airway, an LMA.
LMA, okay.
It's essentially a large bore tube with an inflatable mask at the end, and it's designed to seal around the glottis. That's the opening to the trachea.
So it's like a temporary snorkel, a more secure airway.
Exactly. And it's really helpful because it offers better ventilation than a bag valve mask and reduces the risk of gastric distension, where air goes into the stomach instead of the lungs.
Oh, wow. That's a problem I wouldn't have thought of.
It can be.
So it's like a bridge between basic airway management and intubation.
Exactly.
Now, what about emergency situations where you can't intubate with a traditional endotracheal tube? SSD Simoneau's materials mention some other devices like the esophageal tracheal combo tube, or ETC, and the King tube. Those sound pretty intense.
They're definitely for those high-pressure moments, like in pre-hospital settings or emergencies when you need an airway fast.
And traditional intubation isn't an option.
Right. The ETC, for example, is a dual-lumen airway that's blindly inserted. And here's the thing, it works whether it ends up in the trachea or the esophagus.
Wait, so it doesn't matter where it lands.
It's pretty cool. See, the ETC has 2 balloons and 2 channels for airflow. If it's in the esophagus, one balloon blocks air from going into the stomach, and the other lets us ventilate through a small opening above that balloon.
Okay, I'm following so far.
Now, if it lands in the trachea, the other balloon seals around the tube, and we can ventilate directly through it.
So it's like a 2-for-1 airway solution.
You got it.
That's amazing. What about the King tube? I noticed the materials mentioned choosing the correct size based on the patient's height. Why height?
Good question. So the King tube has 2 inflatable cuffs that isolate the airway. If the tube is too short, that upper cuff might not seal properly, and that increases the risk of aspiration. But if it's too long, it can press on the vocal cords and even cause damage.
That makes sense. It has to be just right.
Exactly. Using the patient's height helps us pick the best size to be both effective and safe.
Okay, we've covered a lot with basic airway management. Let's move on to endotracheal tubes, the ETTs.
Right.
These are the go-to for long-term airway management, right?
They are. When someone needs an artificial airway for a while, an ETT is usually what we use.
The course material even breaks down the anatomy of an ETT. It talks about the radiopaque line, which helps see it on X-rays, and the Murphy eye, a small hole that lets air through, even if the tip's blocked.
Yeah, the Murphy eye is pretty ingenious.
So it's a backup ventilation route. Why would that be necessary?
Think of it as a safety feature. If the ETT tip gets clogged by secretions or if it kinks, the Murphy eye still lets air reach the lungs.
Oh, that's clever. It's amazing how much thought goes into designing these things. Now, there's also a cuff on the ETT. What's that for?
The cuff seals the trachea to prevent air from leaking out, especially during positive pressure ventilation.
So it's keeping the air going where it needs to go.
It's like when you inflate a bike tire. It creates that airtight seal.
Ah, so all the air from the ventilator goes directly into the lungs. I'm guessing there are different kinds of cuffs.
You bet. We have high-volume, low-pressure cuffs and low-volume, high-pressure cuffs. There are also foam-filled cuffs. Each one has its own implications for how we manage pressure in the trachea and prevent complications.
So like inflating a bike tire versus a car tire. Different pressures.
Good analogy. High-volume, low-pressure cuffs need more air to inflate but put less pressure on the tracheal wall. Low-volume, high-pressure cuffs need less air but exert more pressure.
So finding that right balance is key. What about specialty ETTs? There's a whole list in the course materials.
Oh yeah, ETTs for specific situations, like the dual lumen tube. Imagine a patient who needs surgery on just one lung. This tube lets us ventilate each lung separately, like having two airways in one.
Oh, that's wild. It'd be essential for something like that.
Exactly. There are also ETTs with features like subglottic suction to remove secretions above the cuff, wire-reinforced tubes for stability, and even nasal tubes for patients who can't have an oral tube.
So many variations. It's impressive.
Each type serves a specific purpose, addresses a particular need.
Okay, let's move on to the actual process of intubation. That's when things get serious, right?
It definitely requires precision and knowledge. It's about inserting that ETT either through the mouth or nose into the trachea to establish an artificial airway.
That sounds a bit intimidating. Are there a lot of things that could go wrong?
There are risks, for sure. We have to be very careful to avoid things like airway trauma, expiration, or even damage to the teeth or vocal cords.
And what about patients with existing neck problems?
That's another consideration. There's even a slight risk of spinal cord injury.
But isn't intubation risky? Why not just avoid it?
It's a necessary intervention in many situations. If a patient can't breathe on their own, or if we need to protect their airway during surgery, intubation becomes essential.
So it's a calculated risk. The benefits outweigh the potential problems.
Often, yes.
What factors determine if intubation is necessary?
There are certain indications we look for. For example, if their breathing rate is dangerously high or low, or their oxygen levels are critically low despite giving them oxygen.
So it's not just about breathing difficulty, it's the whole picture.
Right. We also consider things like if they have a decreased level of consciousness and can't protect their airway on their own.
So it's about understanding their overall condition. Now, the intubation procedure itself, that sounds pretty complex.
It is a multi-step process. Before we even begin, we assess the patient for potential difficulties. Things like how wide they can open their mouth, the distance between their thyroid cartilage and their chin, and the Mallampati score. That score helps us predict how easy or difficult it might be to see the vocal cords.
Like a pre-flight check.
Exactly.
Okay, what's next? Walk me through the actual intubation.
So once we've done the assessment and have all our equipment ready, the laryngoscope, blades, McGill forceps, we give the patient medication. This sedates and paralyzes them to ensure their comfort and minimize resistance.
I imagine that's for everyone's benefit.
Yes. Then we use the laryngoscope to see the vocal cords and carefully guide the ETT through them and into the trachea.
That sounds incredibly precise.
It is.
How do you make sure the tube is in the right place? What if it goes down the wrong way?
That's critical. We use a few methods to confirm placement. We listen for breath sounds over both lungs, watch for their chest rising and falling, and use a device called a colorimetric CO2 detector. It changes color if CO2 is present in their breath. We also use capnography, which continuously monitors CO2 levels. Then, for final confirmation, we get a chest X-ray to see the tube's position.
So it's a multi-layered approach to be absolutely certain.
We want to be sure.
That's reassuring. And once it's in, then what?
We secure the tube carefully so it doesn't come out accidentally, inflate the cuff to create that seal we talked about, and connect the patient to a ventilator if needed.
It's amazing how much goes into simply breathing. But things don't always go smoothly, right? That's why the next part of the course focuses on airway emergencies.
True, emergencies can happen anytime. They require quick thinking and action.
What are some of the more common emergencies?
Well, there's tube obstruction, cuff leaks, and accidental extubation.
Tube obstruction sounds scary. How does that happen, and how do you know it's happening?
Well, the tube could kink, the cuff might herniate, or it could get blocked by secretions. We usually notice an increase in the peak pressures on the ventilator. That tells us something's blocking the airflow.
Like a clogged pipe.
Yeah, something like that.
So what do you do?
It depends on what's causing it. We might reposition their head, suction the tube to remove secretions, or deflate and reinflate the cuff. If it's really bad, we might have to remove and replace the tube, but we'd use an exchange catheter to minimize the risk of losing the airway completely.
It's a lot to handle under pressure.
It can be.
What about cuff leaks?
Those can happen if there's a problem with the pilot balloon, the pilot tube, or the cuff itself. We'd see a decrease in peak pressures on the ventilator, or we might even hear air leaking around the tube.
Is that a common occurrence?
Sometimes, if the leak is big enough, the patient might be able to talk.
They can talk while intubated.
It's possible. It definitely means the cuff isn't sealing properly. The tricky part is figuring out where that leak is coming from.
So you have to do some investigating.
Right. Is it the cuff, the tubing, or the balloon controlling the cuff's inflation?
Once you've identified the source, what happens next?
Well, then we can decide how to manage it. Sometimes just adding a bit more air to the cuff does the trick. Other times, we might need to replace the pilot balloon or tubing. And if it's the cuff itself, we might need to re-intubate with a new tube.
There's a lot of problem solving. What about accidental extubation? That sounds like the worst case scenario.
It's definitely serious. That's when the ETT comes out, either partially or completely.
How does that happen?
It could be from inadequate sedation, the tube not being secured properly, or even the patient moving around a lot, especially if they're agitated.
What are the consequences of that? What do you do?
It can lead to things like laryngospasm, laryngeal edema, and even respiratory failure. We need to act fast and reestablish the airway, maybe by reinserting the original tube or using a different technique like an LMA or a bag valve mask.
Like a race against the clock. Are there ways to prevent it from happening in the first place?
Definitely. We focus on meticulous attention to detail, proper securing techniques, and making sure the patient is adequately sedated. We also keep an eye out for things that can increase the risk, like excessive sweating, coughing, or agitation.
So being proactive is key. Okay, let's shift gears to extubation, removing the ETT. How do you know when a patient's ready for that, and what are the main considerations?
Extubation is a big step in recovery. It's when they can breathe on their own again.
It must be a relief for everyone.
It is, but we need to be absolutely sure they're ready.
What factors do you consider?
We look at their level of consciousness, if they can cough and protect their airway, their respiratory rate, the oxygen saturation levels, and their overall clinical stability. We also use tools like the Wright spirometer, which measures lung volume, and the inspiratory force manometer to check their inspiratory muscle strength.
So it's a thorough assessment to make sure they can breathe on their own.
Exactly.
What does the actual extubation procedure look like?
It's relatively straightforward. We suction the airway to clear any secretions, deflate the cuff, and gently remove the tube. But the time after extubation is just as important. We have to monitor them closely for any signs of trouble, like shortness of breath, changes in their breathing, or drops in oxygen saturation.
It's about making sure they're stable on their own.
Right.
Okay, let's talk about tracheostomy care. This is for long-term airway management, right?
Yes, when a patient needs that long-term support, a tracheostomy tube is their lifeline.
What is a tracheostomy exactly?
It's a surgical procedure that creates an opening in the neck called a stoma that goes directly into the trachea. Then we put a tracheostomy tube through that opening to provide the airway and let us suction out secretions.
Why would someone need a tracheostomy? Is it only for people who can't breathe at all on their own?
There are a few reasons. It might be necessary if they have a severe airway obstruction, if they need to be on a ventilator for a long time, or if they have a condition that affects their swallowing, making it hard for them to protect their airway.
So a solution for a range of problems. What about tracheostomy care? Is that complex?
It involves keeping the airway open, preventing infections, and making sure the patient is comfortable.
I bet that's a lot of work.
It's a multi-step process. We clean the stoma and the tracheostomy tube, suction secretions, and change the inner cannula, the part of the tube that's removable.
Sounds pretty detailed.
It is.
What are the key things to remember when providing tracheostomy care?
Sterility is crucial. We use sterile gloves, basins, brushes, and hydrogen peroxide to clean everything. We have to be careful not to damage the tissues around the stoma.
It's about being both thorough and gentle.
Exactly. We also need to regularly check the stoma for any signs of infection, like redness, swelling, pus, or a bad smell. And of course, we make sure the tracheostomy tube is secure and in the right place.
It's a lot to keep track of.
You're right. Now, while tracheostomy care is for long-term management, we also have to think about suctioning to clear secretions. It's a very common procedure, but not without its risks.
Okay, let's talk about suctioning. Why is it important, and what are the potential dangers?
Well, our airways are always producing mucus to protect our lungs, but in critical care, patients often have more secretions because of illness, injury, or the artificial airway itself.
So their bodies are working overtime.
In a way, yes. And these secretions can block the airway, making it hard to breathe and increasing the risk of infection. That's where suctioning comes in to help clear things out and keep the airway open.
It makes sense, but you mentioned risks.
Yes, suctioning can cause complications like hypoxia, which is a drop in blood oxygen levels, bradycardia, a slow heart rate, and even trauma to the lining of the airway.
That doesn't sound good.
No, so we take steps to minimize those risks. We always pre-oxygenate the patient, use the right size catheter, and limit suctioning time to prevent hypoxia. And of course, we use sterile technique to avoid infection.
So, careful and controlled. Now, the materials briefly mention a mini bronchoalveolar lavage, or mini BL. What's that?
It's a way to examine what's happening deep in the lungs.
How do you do that?
We instill a small amount of sterile saline into the lungs and then suction it back out. We can then analyze the fluid for bacteria, viruses, or other things that might be causing problems.
Like a little investigation inside the lungs.
It is.
So, we've talked a lot about airway management, from the basics to some pretty complex procedures. Let's move on to patient monitoring in the ICU.
Sounds good.
It seems like you're surrounded by data and technology in that setting.
That's one way to put it. We rely on a lot of information to understand the patient's condition and make decisions about their care. We should probably start with respiratory monitoring since that's been our focus.
Yeah, right.
I know there are a lot of measurements involved in assessing how someone is breathing. It's a little overwhelming.
I understand. Each measurement gives us a piece of the puzzle, though. So there's oxygenation, which is how well the lungs deliver oxygen to the body. And then there's ventilation, which focuses on how effectively they're moving air in and out.
Okay, that helps. What are some of the key measurements for oxygenation? We have PaO2, which is the partial pressure of oxygen in the blood. Then there's SO2, the percentage of hemoglobin saturated with oxygen, and SpO2, which is a non-invasive measure of oxygen saturation we get from a pulse oximeter.
So multiple ways to look at oxygen levels. What about for ventilation?
We monitor respiratory rate, which is just the number of breaths per minute. We also measure tidal volume, the amount of air breathed in and out with each breath, and minute ventilation, which is the total volume of air moving through the lungs each minute.
So like monitoring traffic flow, but for air.
Exactly. We also look at PaCO2, the partial pressure of carbon dioxide in the blood. That tells us how well the lungs are getting rid of CO2. And then there's capnography, which gives us continuous monitoring of CO2 in the breath.
We'll have to come back to capnography. It sounds interesting. What about other aspects of respiratory monitoring?
There's also dead space. That's the volume of air that's breathed in but doesn't actually participate in gas exchange. There's anatomical dead space, which is the air in the conducting airways, and alveolar dead space, which is the air in alveoli that aren't getting blood flow.
So it's air that's not doing its job.
Right. And conditions like pulmonary embolism, emphysema, and shock can increase that alveolar dead space, making it even harder to get oxygen to the body.
Wow. So much to consider.
We can calculate the ratio of dead space to tidal volume, or VDVT, to assess how efficiently ventilation is happening.
It's amazing how much is involved in something as basic as breathing.
The body is a complex system.
It really is.
Now, speaking of complex systems, let's move on to neurological monitoring. The brain is the control center, so keeping an eye on its function is crucial in critical care.
That makes sense. What are some of the main assessments used for neurological function?
One of the fundamentals is the neurological exam. It involves looking at their mental status, how their pupils react to light, their eye movements, reflexes, and motor and sensory function. It gives us a broad picture of their nervous system.
It's a very thorough examination.
We want to be thorough.
What if you need more detailed information? The materials mentioned intracranial pressure monitoring, or ICP monitoring.
Right. ICP monitoring is more invasive, but it's invaluable. It lets us directly measure the pressure inside the skull. This is critical for conditions like traumatic brain injury, stroke, and hydrocephalus, where pressure in the skull can damage the brain.
So you're actually measuring the pressure in their head.
Exactly.
How do you do that?
There are different techniques. Things like intraventricular catheters, subdural screws, and epidural sensors. These devices go inside the skull and allow us to continuously track pressure changes. We also calculate something called cerebral perfusion pressure, or CPP, which is the pressure gradient driving blood flow to the brain.
So maintaining a healthy blood flow to the brain without too much pressure. It's all about balance.
It is.
Are there any simpler ways to assess neurological status?
Of course. The Glasgow Coma Scale, or GCS, is a commonly used tool. It scores the patient's level of consciousness based on eye-opening, verbal response, and motor response.
So a quick way to gauge the severity of a brain injury.
Exactly. Now, we also monitor other vital organs, like the kidneys and liver, which are essential in critical care.
So it's a whole body approach.
Always. For renal function, we're looking at how well the kidneys filter waste and regulate electrolytes. We track measurements like BUN, creatinine, potassium levels, and urine output.
And the liver.
For the liver, we monitor liver function tests, or LFTs. These check the levels of enzymes and proteins that are released into the bloodstream if the liver is damaged.
So you're looking for signs of trouble.
Right.
And to bring it all together, we have global monitoring indices, right? These give an overall assessment of how sick a patient is and their risk.
They do. Indices like the Apache 2 score incorporate a range of physiological variables. It's like a score that reflects how complex their condition is.
So the higher the score, the more serious the situation.
Exactly. These scores help us understand if what we're doing is working, predict potential outcomes, and standardize our approach to care.
Okay, we've talked about a lot of data and monitoring, but I want to touch on something we haven't explicitly discussed, the human element of critical care.
That's an important aspect. It's easy to get caught up in the technology, but we're dealing with real people in life-threatening situations.
It must be incredibly stressful to make those high-stakes decisions based on the data, to manage complex airways, knowing that things can change so quickly.
It's a demanding field, that's for sure. Compassion fatigue and burnout are real concerns.
So how do healthcare professionals cope with the emotional toll of this work?
It's a complex issue that deserves more discussion. But self-care, strong support systems, and a shared sense of purpose are all crucial.
It's a good reminder that behind all the data, there are human stories. Stories of hope, resilience, and connection.
You're absolutely right.
Let's keep those in mind as we continue exploring the world of critical care.
It's incredible how even something as simple as how a patient is lying in bed can affect their breathing and recovery.
You're right. I never really thought about positioning as a critical care intervention. But SSGT Semino's materials really emphasize that point. So let's break it down. What are some of the positions you use and how do they impact breathing?
Well, think about someone having trouble breathing. What's the first thing you do? You prop them up with pillows, right?
Yeah, to help them breathe easier.
Exactly. And that's the idea behind positions like Fowler's and semi-Fowler's.
Okay, so it's like giving gravity a helping hand. But why does that make a difference?
When their upper body's elevated, it gives the diaphragm more room to move. That makes it easier for the lungs to expand.
So more space for the lungs to do their job.
Right. It's especially helpful for patients with heart failure or COPD, where fluid buildup or narrowed airways make it tough to breathe.
What about the side-lying position? I think that's called lateral decubitus.
That's right. Think about a patient with pneumonia in one lung. Lying on their side with the good lung up helps that healthy lung work better.
Makes sense. What about when you need to get fluids or secretions out? Are there positions for that?
Definitely. We have the Sims position. It's a kind of modified side-lying position where the patient's partially on their stomach.
Okay.
That helps drain stuff from the mouth and sometimes from the lungs.
Interesting. So even simple adjustments can make a difference. What about those more dramatic positions like Trendelenburg, where the head is lower than the feet? That seems counterintuitive for breathing.
You're right. Trendelenburg isn't typically used for breathing problems. It's mainly for situations like severe low blood pressure or shock.
So you're trying to get blood flow back to the heart quickly.
Exactly.
But wouldn't that make it harder to breathe?
It can, yeah. While Trendelenburg is helpful in certain emergencies, it can also put more pressure on the diaphragm, making it harder for the lungs to expand. So we only use it for a short time and carefully.
It's a balancing act.
It is.
What about the opposite? Reverse Trendelenburg, with the head up and feet down.
Reverse Trendelenburg is more for gastrointestinal issues like reflux or during surgeries to help see the abdominal area better, not really for respiratory management.
Got it. So each position has its own purpose. What about just lying flat on their back? Supine.
While that might seem like the most natural position, it can actually increase the risk of aspiration, especially for unconscious patients or those with swallowing problems.
Aspiration, meaning stuff getting into the lungs.
Right. When someone's flat on their back, it's easier for saliva, food, or even stomach contents to go up the esophagus and into the trachea, which can cause lung infections.
So even lying flat has to be considered carefully.
Definitely. Now, you might think lying on the stomach prone would make breathing harder.
I would think so, yeah.
But actually, the prone position has become really important in managing patients with severe respiratory distress, especially those with ARDs.
ARDs, acute respiratory distress syndrome.
Yeah. Studies have shown that proning these patients can improve oxygenation and lung function.
So lying on their stomachs actually helps them breathe better. How?
It seems counterintuitive, but we think it works by improving something called ventilation perfusion matching.
Meaning?
Basically, it means more air gets to the parts of the lungs where the blood flow is good, and it helps open up collapsed alveoli, the tiny air sacs where gas exchange happens.
So it's getting more of the lungs involved in breathing.
Exactly. But it's not as simple as just flipping someone over.
Right, I can imagine there are other considerations.
Absolutely. Proning is a complex procedure. We need to think about patient comfort, making sure their airways managed properly, preventing pressure sores, and watching for complications.
Definitely a team effort. What about the beds themselves? Are there special beds to help with positioning?
Oh yeah, we have rotating beds that can help prevent pressure sores and keep the lungs clear by changing the patient's position regularly. And then there are beds specifically designed for proning.
That sounds interesting.
These beds have features like adjustable frames, padding, and even turning systems to make proning easier and safer.
It's great that there's technology to help with that.
Mm.
Okay, we've talked a lot about positioning. Let's switch gears to pneumothorax, a collapsed lung.
All right.
That's when air leaks into the space between the lung and chest wall, right?
That's it. It can happen spontaneously from trauma or even as a complication of a procedure.
The materials mention two procedures to treat it: needle thoracentesis, or needle decompression, and percutaneous thoracotomy, which is basically inserting a chest tube.
Right.
Both involve getting into the pleural space, but it seems they're for slightly different purposes.
Yes, needle thoracentesis is usually an emergency procedure. It's for quickly relieving pressure on the lung in a tension pneumothorax.
And that's a life-threatening situation.
Absolutely. Think of a one-way valve. Air can get in but can't get out, so the pressure keeps building, squeezing the lung and pushing on the heart and other organs.
That sounds terrifying.
We have to act fast.
So needle decompression is like quickly letting the air out of a balloon.
That's a good way to think about it. We insert a needle through the chest wall into the pleural space to let the trapped air escape. It buys us some time.
But it's not a permanent fix.
No, it doesn't address the root cause. That's where chest tube insertion comes in.
Right, that's a more permanent solution.
A chest tube is a bigger tube that lets us remove not only air, but also blood or fluid in the pleural space. It acts as a drain to help the lung re-expand and heal.
So needle decompression is a quick fix, and chest tube insertion is more long-term. How do you decide which one to use?
We consider how severe the pneumothorax is, the patient's overall condition, and the risks and benefits of each procedure. Needle decompression is less invasive, but might not be enough for large pneumothoraces, or if air is building up quickly. Chest tube insertion is better in those cases, but there's a slightly higher chance of complications.
Are these procedures risky?
Anytime you're puncturing the chest wall, there are risks. We could damage the lung, blood vessels, or nerves, so we have to be incredibly careful. The course materials emphasize proper technique and knowing your anatomy really well.
Makes sense. The materials also mention different chest tubes and drainage systems.
There are a few options, yeah. Picking the right size and type depends on the situation.
How so?
Well, for a pneumothorax that's just air, a smaller tube might be fine. If there's blood or fluid, we'll need a larger tube with suction.
So many factors to consider.
There are.
What about after the procedure?
Post-procedure care is really important. We want to ensure the chest tube's working, watch for problems, and help the lung heal. We always do a chest x-ray afterward to make sure the tube is where it should be and the lung is re-expanding.
What else do you monitor? The materials mention a water seal chamber.
The water seal chamber is part of the chest tube drainage system. It lets air and fluid out but prevents air from going back in. We watch the water level in the chamber, which goes up and down with the patient's breathing. And we look for bubbling, which means there might still be an air leak.
It's like a visual cue.
It is. We also constantly monitor the patient's vital signs, oxygen levels, and breathing patterns, and we listen to their lungs to check for any changes that could indicate a problem.
So you're always on the lookout.
We want to anticipate any potential complications.
Okay, we've covered a lot, from basic airway management to complex things like chest tube insertion.
We have.
Now, I'm really curious about this capnography thing we touched on earlier. It seems like a powerful tool.
It is. It's like having a direct line to the lungs, letting us track CO2 levels in the breath.
And CO2 levels are important because...
Well, CO2 is a byproduct of metabolism, and it's the lungs' job to get rid of it.
Right.
So by monitoring CO2, we can see how well ventilation, perfusion, and even metabolism are working.
It's more than just breathing.
It is. It's about how the body's using oxygen and creating energy.
Okay, let's dive into this.
Okay.
There are two types of capnography. Mainstream and side stream, right?
Okay.
What's the difference?
Mainstream capnography means putting the sensor directly in the patient's airway. It's the most accurate and quickest way to measure, but those sensors can be a bit bulky, especially for smaller patients.
So accuracy, but not always practical.
Right. Side stream capnography uses a small adapter to take a sample of the breath and send it to a separate analyzer.
Okay.
It's less invasive and more flexible, but things like water vapor or secretions in the line can affect the readings.
A trade-off then.
We could say that.
So regardless of the type, the information from capnography seems really valuable.
Oh, it is.
How is it used in critical care?
Capnography is useful for a lot of things, like
Okay.
confirming endotracheal tube placement and checking how well CPR is working.
Wait, it can tell you if someone's heart has restarted during CPR.
It can. See, during CPR, if the chest compressions are working, CO2 will build up in the blood. When the heart restarts, that CO2 goes to the lungs and gets exhaled. We see this as a sudden jump in the ETCO2 level, the CO2 at the end of exhalation.
It's like a signal that the heart's back online.
Exactly. And it's also really important for making sure the ETT is in the right place after intubation. That CO2 waveform on the monitor tells us right away that the tube is in the trachea, not the esophagus.
So you're not accidentally ventilating the stomach.
Right.
Now, the materials also mention colorimetric CO2 detectors. Are those related to capnography?
They are. Those are disposable devices that change color when they detect CO2. They're a quick way to check tube placement, but they're not as accurate or reliable as electronic capnography for continuous monitoring.
So a quick visual check, but not for ongoing use. What about assessing the patient's breathing in general?
Capnography gives us real-time feedback on how well ventilation is happening.
Real time.
Yes, we can see how much CO2 the patient is breathing out.
Okay.
This helps us make adjustments to the ventilator, find any blockages, and catch any changes in lung function.
It's like a window into their lungs.
It is. And the course materials do a really good job of explaining how to interpret those CO2 waveforms. It looks at 5 main things: height, frequency, rhythm, baseline, and shape. It's like learning a new language.
Let's break that down. What does the height of the waveform tell you?
The height shows how much CO2 is being exhaled. A taller waveform means more CO2 is being removed, and a shorter one means less.
So it's directly related.
Yes. Now, the frequency of the waveform matches the respiratory rate. A faster waveform means they're breathing faster, and a slower one means they're breathing slower.
Okay, so height is CO2 amount, and frequency is breathing rate. What about rhythm?
Rhythm tells us about the regularity of the breaths.
Consistent or not?
Right. A normal capnogram should have a regular, steady rhythm. If there are irregularities, like pauses or changes in the spacing, it could mean there's a problem.
What about the baseline?
The baseline should ideally be 0, showing that all the CO2 from the last breath is gone. If the baseline is elevated, it could mean they're rebreathing CO2 or there's a problem with the equipment.
Interesting. So it's like resetting between breaths.
Yes. And lastly, there's the shape of the waveform.
Okay.
That can give us clues about lung function and ventilation perfusion matching. A normal capnogram has a rectangular shape with a flat plateau, which represents the alveolar gas concentration. If the shape changes, like a sloping plateau or a shark fin appearance, it could mean an airway obstruction or a pulmonary embolism.
Wow, who knew there was so much information in a CO2 waveform?
It really is a language all its own, and understanding it helps us provide better care for our patients.
Absolutely. Capnography has really changed the game in critical care.
It's helped us catch problems early and make more informed treatment decisions. It's an invaluable tool.
Capnography really has changed how we look at respiratory monitoring. It's like a window into what's happening in the lungs.
It's an incredible tool giving us information we never had before.
Now, we've talked a lot about airways, but there's another crucial part of critical care that SSGT Simonos materials cover hemodynamics. I'll admit, it's a bit intimidating.
It can seem that way, but it's all about the forces that move blood through the body. Think of it like the body's plumbing system.
Okay, plumbing I can understand. So instead of pipes and valves, we have blood vessels in the heart.
Exactly. And we need to understand how they all work together.
So what are some of the key things to know about hemodynamics?
Well, there's cardiac output. That's the volume of blood pumped by the heart every minute.
Like a measure of how much work the heart's doing.
You could say that.
What affects cardiac output?
A few things. Heart rate, how fast the heart's beating. Stroke volume, the amount of blood ejected with each beat. And preload, the amount of blood returning to the heart.
Preload.
Yeah, the blood coming back to the heart stretches the heart muscle, which influences how strongly it contracts.
So it's like a chain reaction.
It is.
What about blood pressure? That's always a big deal.
Blood pressure is the force of blood against the artery walls. It tells us a lot about the health of the circulatory system. We measure systolic pressure when the heart contracts and diastolic pressure when the heart relaxes.
So many things to keep track of. How do you monitor all of this in the ICU?
We have different tools. For basic monitoring, there are non-invasive things like blood pressure cuffs and pulse oximeters.
Considered stuff.
Right. But for more detail, we might use an arterial line.
With that.
It's a thin tube inserted into an artery to give us continuous blood pressure readings. It also lets us take blood samples easily.
That makes sense. So you can get those readings constantly and draw blood without having to poke them repeatedly. What about measuring cardiac output directly?
We have techniques for that, like the thermodilution method and the pulse contour analysis method.
That's pretty complicated.
They can be. Thermodilution involves injecting a cold solution into a central line and measuring the temperature change as it mixes with blood.
Okay.
Pulse contour analysis uses some fancy math to estimate cardiac output from the shape of the arterial pressure waveform.
Wow, that's high tech. Now, what about monitoring the heart itself? There's the EKG, right?
The EKG, or electrocardiogram, shows us the heart's electrical activity. We can see the heart rate, the rhythm, and if there are any problems with how the electrical signals are moving through the heart.
So it's like listening to the heart's electrical signals.
In a way, yes.
Are there ways to actually see the heart and blood vessels?
Oh, yes. We can use echocardiography, which uses sound waves to make pictures of the heart, and angiography, where we inject a dye into the blood vessels and use X-rays to see their structure.
So we can see if there are any blockages or problems.
Exactly. These imaging techniques tell us a lot about how the heart's working and if there are any abnormalities.
It's amazing how much you can learn from all this technology. But with so much information, how do you put it all together and make treatment decisions?
That's where critical thinking comes in. We look at all the data, the patient's symptoms, and their medical history to understand what's going on. Then we use all of that to make a plan to address the root causes of their problems.
So you're like a medical detective.
Something like that. Critical care is about using our knowledge, skills, and all these amazing tools to help our patients get better.
And with that, we've reached the end of our deep dive into critical care.
It's been quite a journey.
We started with airway management, moved on to patient positioning, talked about emergencies, and explored the complexities of hemodynamics and advanced monitoring techniques.
It's a challenging but incredibly rewarding field.
I'm leaving with a much deeper appreciation for the knowledge, skills, and dedication it takes to work in this area.
It really is about the human body's incredible ability to adapt, the constant innovation in technology, and the unwavering commitment of those who care for the sickest patients.
It's been fascinating. To everyone listening, thank you for joining us on this deep dive. We hope you learned something new and are inspired to keep exploring. Until next time.